Incomplete primary surgery. So we know C endometrium is based on surgical staging. If there is surgery has been done and the patient came to you, you have to check whether there is any residual disease or there is no residual disease. If there is no residual disease, in that case, in presumed early stage disease with no residual disease, which is based on the initial surgical report and post surgical imaging, resurgery should be avoided in patients with low risk disease, that is including uterine pathological and molecular factors. If the patient is candidate for surgery, then remove the cervix. That is, in case of no previous lymph node staging, the sentinel lymph node should be assessed by cervical injection. If the sentinel lymph node cannot be detected after injecting the dye, but the sentinel lymph node is not getting detected, then lymph node staging follows the standard principle used in primary surgery. Resurgery with infracolic omentectomy. Indication are serous endometrial carcinoma, carcinosarcoma, and undifferentiated carcinoma confined to the uterus. As sentinel lymph node assessment cannot be done in cases of previous total hysterectomy. In case of previous total hysterectomy, there will be no cervix, so where to inject the dye. Then systematic pelvic lymphadenectomy should be considered only in patients who are not at low risk, and if it can modify adjuvant treatment, since its therapeutic role has not been established yet. If the patient is undergoing resurgery to complete staging, then peritoneal staging, lymph node staging, or cervix removal. Along with that, retained adnexus should be removed, except indication of ovarian preservation, which we discussed in part 1. Residual disease. If there is residual disease, then what to do? If residual lymph node disease is there, then it should be evaluated for resection. If the lymph node is not resectable, then primary systemic therapy accounting for the molecular profile, EBRT, or both. If resectable, then go for lymph node resection. If not resectable, then you can give systemic therapy or radiotherapy. External beam radiotherapy should be delivered to pelvic node with or without paraortic nodes. Residual pelvic disease is there, like vagina, pelvic side wall, or bowel. After that, incomplete surgery, then residual tumor site should be evaluated for resection if the initial surgery did not occur. If not operable, then radiotherapy or systemic therapy. So first is you have to evaluate for surgery. If resectable, then remove that part. If not resectable, then you can give systemic, that is chemotherapy, or you can give radiotherapy, external beam radiotherapy plus intracavitary brachytherapy. Recurrent diseases. You have to check whether there is locoregional recurrence disease or distance recurrence disease. If there is locoregional disease, then check history properly whether she has received radiotherapy or not. If radiotherapy not received, that is radiotherapy naive patient, then preferred treatment is external beam radiotherapy plus minus image guided brachytherapy plus minus chemotherapy, but radiotherapy to give if she has not received radiotherapy and a recurrence is there. And for vaginal cough recurrence, pelvic external beam radiotherapy plus intracavitary image guided brachytherapy is preferred. And in case of superficial tumor, intracavitary brachytherapy according to image alone is sufficient. No need to give external beam radiotherapy. And in case of superficial vaginal tumor, then you have to resect vaginally first prior to the radiotherapy. Then if she has received brachytherapy only, then external beam radiotherapy plus image guided brachytherapy boost to give. If she has received external beam radiotherapy, then you have to check the feasibility of radical surgery with clear margin, with acceptable morbidity is there or not. That is to check for surgery, feasible for surgery. If feasible for surgery, then consider molecular subtype and radical surgery to opt. In case of MMRD tumor, that is after doing molecular subtype, it came as MMRD mismatch repair deficient tumor, then chemo plus immune checkpoint immune inhibitor followed by immune checkpoint inhibitor to give. If surgical margin cannot be negative, then primary systemic therapy plus minus immune checkpoint inhibitor to give. Re-irradiation with curative intent in a specialized center can be considered. Then comes the non-locoregional recurrent disease, that is oligometastatic disease or disseminated recurrent disease. Oligometastatic disease is known as 1 to 5 meds up to 3 regions. So in oligometastatic disease, local therapy is preferred, that is surgery and or radiation therapy including stereotactic radiotherapy or local ablating techniques followed by systemic therapy. In disseminated disease, You have to check whether there is feasibility for surgery or not. If feasible for surgery, then go ahead with surgery followed by systemic therapy or radiotherapy. If not feasible for surgery, then systemic therapy plus minus palliative intervention, either palliative surgery or palliative radiotherapy. Next comes the unresectable stage 3 or 4 or a recurrent endometrial carcinoma with no prior chemotherapy except in the adjuvant setting. So first line therapy. You have to check whether it is mismatch repair deficient tumor or non-mismatch repair deficient tumor. In case of MMRD tumor, chemotherapy plus immune checkpoint inhibitor followed by immune checkpoint inhibitor as maintenance therapy is the preferred one. And in non-MMRD tumor, you have to check symptomatic advanced disease or rapidly growing recurrent disease. If chemotherapy can be given, then it is the preferred one. If contraindicated, then pembrolizumab plus lenvatinib to give. And addition of immune checkpoint inhibitor to chemotherapy followed by immune checkpoint inhibitor as maintenance therapy can be an option. And addition of immune checkpoint inhibitor to chemotherapy followed by immune checkpoint inhibitor plus PARP inhibitor as maintenance therapy is also an option. If immune checkpoint inhibitor is contraindicated, that is you can't add immune checkpoint inhibitor, then in case of a patient with HER2 3+ tumor, addition of trastuzumab to that chemotherapy is considered. And in case of low grade estrogen receptor positive patient, low volume or asymptomatic advanced disease, slow growing recurrent disease, then endocrine therapy, medroxyprogesterone acetate or megestrol acetate, aromatase inhibitor, tamoxifen is the preferred one. Second line systemic therapy in unresectable recurrent disease after first line platinum based chemotherapy, that is you give chemotherapy paclitaxel plus carboplatin and it has not responded. So what next to do? In unresectable recurrent disease after first line platinum based chemotherapy, you check that immune checkpoint inhibitor was the part of the first line therapy or not. If no, then add immune checkpoint inhibitor in second line therapy. Also do repeat MMR testing. If MMRD tumor is, then immune checkpoint monotherapy is sufficient and you can consider pembrolizumab plus lenvatinib. If non-MMRD tumor, then you have to check whether it is suitable for pembrolizumab and lenvatinib. If suitable, then give that. If not suitable, then systemic therapy like chemotherapy, platinum combination or doxorubicin or weekly paclitaxel or endocrine therapy or patient in HER2 overexpressing tumor, the targeting strategy like trastuzumab to give. If immune checkpoint inhibitor was the first line part of the first line therapy, then directly give systemic therapy. Follow-up. You have to actively inform and counsel about their follow-up. Shown that patients with endometrial carcinoma should be informed that the primary objectives of follow-up include psychosocial assistance and the detection of health problems. But there is no evidence that follow-up visits improve overall survival. Thank you.